Trial design. RELIEF is a multi-centre, open, two-group parallel randomised control trial. We need 100 plus primary care practices from within England, Scotland and Wales. Our intervention arm is daily low-dose inhaled corticosteroids such as Clenil and combined ICS formoterol, and this is versus the usual care arm, daily low-dose ICS and salbutamol. Patients are randomised on a 1-to-1 ratio. Recruitment. We require 2,300 patients overall across the 100 plus primary care practices. Approximately 23 patients will be recruited per site, but this is depending on search figures, practice catchment zone and patient engagement, etc. There is a 15-month recruitment window overall, which started in March 23 and ends in May 2024. There is a rapid recruitment rate at site level of approximately 3 months. However, this is not a fixed time window. Follow-up activities are coordinated by site and monitored and supported by the NCTU. Our primary objective and outcome is to compare the time to the first severe asthma exacerbation defined as treated with 3 or more consecutive days of systemic corticosteroids, and this in patients using regular low-dose inhaled corticosteroid and randomised to either salbutamol, SABA or the combined ICS formoterol for symptom relief. From month 2 to 11, patients will receive an automated text message, and this sent from the NCTU, asking if they've had a severe asthma attack needing 3 or more consecutive days of systemic corticosteroids, and this being predominantly prednisolone. The numbers are expected to be low in this population, 15% of the total patients recruited per site, so approximately 3 patients randomised into the trial across 12 months. Patients are asked to reply yes or no, and site staff will follow up the yes replies with a phone call to ask the patient about the asthma attack. There are a few questions on the follow-up form held on the trial database to guide you. Our secondary objective and outcomes. To compare the overall inhaled corticosteroid dose used in both groups as a marker of safety. To compare the number of severe asthma exacerbations, including number of hospital attendances. To compare the cost effectiveness of the two strategies, and to explore healthcare professionals and patients' views of replacing the salbutamol inhaler, the sub-study, but more on that later. There are 3 patient-facing questionnaires we have licensed to deliver online, and there are examples on the next slide. The patient questionnaires include a health questionnaire, the asthma control questionnaire, and a health economics questionnaire. All questionnaires are relatively short and are collected at various time points throughout the trial. Pharmacy. Inhalers are not supplied to sites from the NCTU or sponsor. Site staff or the GP are to prescribe as per standard practice. There is no additional trial-specific labelling or accountability needed, and sites should maintain their local accountability and dispensing records as per routine practice. Blinding and unblinding. This is an open label trial, so no emergency unblinding procedures are necessary. Patients, site staff, the NCTU trial management and data coordinators will not be blinded. However, the NCTU trial statistician and trial steering committee will remain blinded to treatment allocations.